Hello, everyone. We're going to give it a few minutes until everyone comes in. Okay, good afternoon, everyone. Welcome to this afternoon's webinar. My name's Verity, and we are going to be discussing and going through the reporting of falls this afternoon. We're just going to wait a few more minutes to see who else we can bring in. So make sure you get comfy, grab a coffee, and then we'll get going. Okay, just going to give it one more minute, and then we'll start with the introductions. Okay, so welcome everyone. Good afternoon. As I said, my name's Verity. I work for HCPA, managing the prevention and enablement team. And this afternoon, we are going to be going through the reporting of falls, including safeguarding and CQC notifications, and also expectations of Hertfordshire County Council. Today you do not have access to your mics or your video. However, you do have access to the chat box or the question and answer. I'm not quite sure which one it is, but please feel free to use that. And at the end, we're going to go through your questions and make sure we can answer as much as we can. But if we don't get to your question, we will make sure we answer after via email. And as always, you will get the recording, you will get the slides, and you will get any resources that we go through today. So I will be going through the aims of today's webinar, and I've also got with me Amanda Bonds from the safeguarding team. I have also want to shout a big thank you out to Jackie and Tarry from Herts County Council, that has helped me along the way and might butt in to make sure I'm speaking sense. And also a big thank you to Amanda number 2 from CQC, that's also supported with the information today. So today's webinar, we're going to be going through what needs to be reported as a safeguarding, Hertfordshire County Council expectations and reporting falls. We're going to be touching on pressure ulcers as well, Regulation 18 guidance, a person who has fallen in a care home pathway, and also surrounding documents, which is going to be suitable for all providers. And also talking a little bit around some of the key trends and themes we're finding out in the county at the moment as we think about falls generally, and go through some interventions and actions as well. Now, it's also important to note as well, I guess, that the reason how this webinar came about was that I find myself writing lots of patterns, lots of trends throughout the county. I'm sure I've spoken to most of you before about falls, and we thought this was a real gap in trying to get some consistency. We have had people just reporting because you're not sure whether you should or shouldn't. So we're really trying to make sure that you've got all the information in one place. And as I said, please use your question and answer box to come back to us with any questions. So I'm going to pass over to Amanda Bonds that is going to be going through about reporting a safeguarding. So Amanda, I'm going to go on mute and it's over to you.
Okay, thank you, Verity. If you can, that's perfect. So thank you for listening today. So yes, my name's Amanda Bonds. I'm the team manager for the west side of Hertfordshire. Obviously, Hertfordshire's a big county, so I have my counterpart on the east, and we do work as one seamless service, and we work very closely as one service. So really, just the first point is rationale. And that's really just was me just kind of sharing with you kind of how Safeguarding Service team was born. It was born in 2019, and before that there wasn't a safeguarding service, but safeguardings would be managed within the different operational teams within adult care services. And we have been developing this service for some time, obviously 4 years now, and we are, I would say, embedded now. So it's been a lot of hard work, and not just us, but all our partners, all of yourselves, all the care homes and care agencies working with us. So thank you very much. The main thing I just wanted to kind of sort of talk about was the portal, the safeguarding portal. That was a long project that took, I think, about 2 years to come to fruition, and you can imagine how many different organisations and providers that we had to work with in order to agree to be able to sign up for this and be able to work with the portal, and it has been a really positive response, and we do receive a lot of referrals from care homes and care agencies, so thank you all very much. And we, that has worked in it really well. It has helped to streamline the nature of the referrals that come in, for us to be able to communicate in a clear way what we're going to do with those referrals and whether they are going to proceed as safeguarding. If not, why not, and what advice do we have? So the safeguarding portal has, in my view, been a success and an extremely important part of the project for bringing together the safeguarding service. All professionals must use the safeguarding portal to make any safeguarding referrals to Hertfordshire County Council. And Verity, this is me, I've been on technical here, but I just can't see the slide because they're all our videos. I'm going to just try and move it. So I might, that's, okay, that's perfect. Sorry about that. I couldn't see the rest of the slide. So professionals must use safeguarding portal to make safeguarding referrals to HCC. This is mandatory now, so we have rolled that out over time and phased it in. It is the most quickest and secure way to make a safeguarding referral. We also have big organisations, the ambulance service, 111, and the police also use, and also GPs use this portal. So all professionals must use the safeguarding portal. This is mandatory. Now, the other thing I wanted to kind of talk about was we do get a lot of safeguarding portal referrals from care homes, care home providers, where someone has fallen, and it feels a bit it does feel when we've reviewed these that a percentage of them are kind of being reported sort of parallel to Regulation 18, but when we have delved further, when we've spoken to the provider or the referrer, there is no concern that someone has fallen as a result of neglect or harm of others. It's sometimes falls do happen, and we know that. So it's just about to be really clear when to send a safeguarding referral in if someone has fallen. I'm just trying to give an example. So, sort of generically, we might receive a safeguarding referral where, Mrs. Smith was mobile. We get a little history, was mobile, and she went to use the toilet and she stood up quickly and then she fell. And maybe it's witnessed or not witnessed, but somebody, a carer, came in straight away and saw Mrs. Smith and dealt with it appropriately, contacting medical advice, usually 111, GP or ambulance, depending on what was appropriate. At that point, it's really to consider whether you as providers feel that fall has happened as a result of neglect of others. So, for example, whether a moving and handling care plan wasn't adhered to, should the person have been monitored, did they have capacity? And often in these cases, they're reported, and when we go back to referrers, they do say, well, we sent a Regulation 18, so we've been told to report. It's just to be really clear that safeguarding referrals are there if they meet that threshold, which we'll go through. But if you feel neglect or abuse has occurred, and the incident has resulted in that. So it's really to look at that history. There's one point that I thought about the other day, and that sometimes falls are unwitnessed as well. Again, it's really to look at the context, to look at yourselves as the provider and the managers to consider whether you feel that neglect has happened, or a fall could have been avoided by the appropriate care. Sometimes if a fall has happened and it's been unwitnessed, and maybe the service user resident can give an account of what's happened, and you're happy that medical assistance or advice has been given promptly and appropriately, and all move and handling care plans have been followed, it's to consider whether that would be a safeguarding, because it really is down to whether, and I know I keep saying it, whether it has happened, you feel, because of neglect or abuse. So it's just to consider that really. But Regulation 18s and safeguardings do not come hand in hand. If you are sending a regulation because you're reporting an incident as stipulated. However, the other way around, if you are stating that you feel that a safeguarding concern needs to be raised, then they do come in hand, and you need to raise a Regulation 18. So it's just to be really mindful of that, and consider when you refer in, are you referring a fall in because you feel that that could have been avoided, or it has occurred perhaps because of lack of action or action of others? Okay. We have sometimes queries or questions around long waits because of the ambulance service. So people sort of waiting for a particular amount of time for an ambulance to come. Obviously, I have discussed this and we've explored these scenarios with the head of service, who's Keith Dodd of Safeguarding. It's not something that we would look at under safeguarding, because it's a national issue. It's the NHS. However, it's obviously it's about an individual. So if you feel, for example, neglect has occurred from an individual, say, for example, a paramedic, that's a different situation. But in general terms, a long wait for an ambulance wouldn't be raised as a safeguard. It doesn't mean to say it wouldn't be escalated through different routes, or different professionals, or the ambulance service themselves, but it wouldn't necessarily be a safeguard, and we wouldn't be able to kind of investigate that. Okay, you're gonna move on now, Verity, thank you. So duties. So safeguarding duties apply when an adult who so there's eligibility. I'm going to keep it a little bit sort of simple. So the 3-tiered questions really under section 42 that we look at to consider whether someone's eligible for a safeguarding investigation or inquiry. So does that person have needs for care and support, and whether or not the local authority is meeting any of those needs? It doesn't mean to say that that person needs to be having formal care provided. They may be getting support from a family member, from somebody that they know, or they might have some private care that they've arranged, or it might be that we've just come to realise that someone has needs for care and support, but they haven't actually got anything in place at all. So it's about that sort of trigger one really. And then it's next to consider, is the person experiencing or at risk of abuse and neglect? Again, it's very low threshold, so it doesn't mean to say that you as providers or anybody, a member of public, needs to know for absolute sure abuse or neglect is happening, but it does mean to say that needs to consider whether you feel that there are concerns, you feel they might be experiencing abuse or neglect, or they just might be at risk of it. That's enough to consider under section 42 of the Care Act. And the third part of that would be, as a result of those care and support needs, if we're saying that Mrs. Smith has care and support needs, and as a result of those, she's unable to protect herself from either the risk or the experience of abuse and neglect, that would look at us triggering an inquiry. So a local authority at that point, if the answer is yes to those three, we would have a duty to investigate. Obviously, the investigation will conclude at different levels, but an inquiry does start. Obviously, we would look at sort of speaking to the service user, the adult at risk, and considering their views as well, and wishes. Just in terms of the safeguarding portal referrals that we do receive, and I can't thank you enough for them. I mean, you all raise, we do get a lot of referrals raised, and sometimes if you're not sure, you do raise them, that's great, but we can still have those conversations with you. Sometimes we do get a lot of information in that summary of concern, and it's just about not saying that we wouldn't want, or some of the information isn't valuable and then we would need it. It's really to consider how much you put in there, because as a duty manager, obviously if I'm a duty manager or any of the safeguarding team are duty managing that day and reviewing them, it's if it's too much information in there, it's quite difficult to really unpick what is the situation. So it's just to consider. Yes, of course, I guess I'm kind of veering towards obviously falls that may have happened in a care home or in the person's own home. The medical history, yes, of course, that could be important, whether they have maybe mental capacity or there's a concern that they might be confused or have a cognitive impairment. Yes, a summary of the event or the incident and relevant information of the concern, but just try not to overshare too much. So if I look at a falls example in a care home, yes, of course, and moving handling is very important, whether they're independent, whether they have a sensor mat, any equipment, whether they require someone to be with them, moving handling scenario for that individual. Of course, details of the event. And obviously this is normally very good in terms of providing information as providers, but just knowing and reporting whether, you know, when medical assistance was sought, for example, was 111 called, an ambulance, was GP. So concise information about the scenario and what's relevant to it, but it's just to bear in mind, not oversharing too much information on that. Okay, Verity, thank you. Okay, so recording the correct category of abuse. Now, again, this has been really great having the portal and embedding the service, because it has really enabled the safeguarding service to work and have good partnerships with providers and organisations, but also just to look at what we can improve, what can be changed, any feedback that can be given, vice versa. And one of the things that we do get a lot is providers reporting categories of abuse, but maybe it's just not being aware of the correct category of abuse, but obviously feeling that, you know, you need to report. And sometimes the category of abuse isn't necessarily the correct one that reflects the incident. So for example, we get a lot of physical abuse put down for if someone's had an injury, but an injury because of a fall, or a skin tear indicated because of an accidental move. It's just to consider other categories of abuse as well. We would look at physical abuse specifically if it's another human being, the provider or a person feels has physically harmed a person. So if someone has fallen and they've sustained, unfortunately, a fracture, you're just feeling that's because of maybe moving handling procedures weren't followed or protocols, it would be likely to be neglect and acts of omission or organisational at times. I'll go through that in a moment, but it wouldn't be physical because it's a physical injury that's occurred. I think that's might be what's happening. People are seeing a physical injury and then reporting physical abuse. But just to be really clear, it's about whether you as a provider feel that another person's physically harmed a resident. So obviously a very clear one would be if a carer or maybe another resident had pushed a resident over. But if someone had fallen and there's no evidence or no indication at all that's caused by another person, but it may be through lack of moving handling, or the person become unwell, or had fallen and you're not too sure, but you're really clear it's not because of another person, then it's really to think about the categories of abuse. So I'll just go through this slide to make it clear. And falls would likely be organisational if it is felt that there are systems lacking that has resulted in a fall. And by that we mean not just an act of one person or two people, maybe carers. It's about whether systems that perhaps should be in place perhaps are not. So organisationally, so for example, maybe moving handling should be perhaps in several residents care plans for assistance of two, but repeatedly only one carer has been able to provide that care. That would be a concern for us, and that would be something we would look at maybe organisationally. Neglect and acts of omission, and again, sometimes there's sort of misconceptions about this. It doesn't mean to say that someone's intentionally carried out actions that might have resulted in neglect. It might be entirely accidental or just for human error, but it would be classed as neglect and acts of omission. And that is as a result of actions from a care professional, others in the care home that has been a result resulting in the fall. So it's just a willful neglect, I think, is maybe what some people might perceive, and they won't they think, well, we can't put neglect and acts of omission down because someone hasn't intended on harming. No, that's not what we're saying. Willful neglect is something entirely different. Neglect and action is just an incident that may have occurred as a result of another professional or a person, perhaps a carer in the care home, that's resulted in that fall. So I've gone through the physical abuse bit, so I won't go through that bottom bit again. That's fine. Thanks, Verity. Okay, so pressure ulcers. So again, the safeguarding service, what's been really valuable is we've been able to really work with the Section 42 categories and understanding as adult care services what we can do to streamline certain themes or categories of abuse or incidences that have occurred. And one of those is pressure ulcers. So the Hertfordshire Safeguarding Adults Board and Keith Dodd have worked together to streamline, maybe focus on pressure ulcers, so that we're giving consistent feedback and working within adult care services, the safeguarding team, but also with other professionals regarding pressure ulcers. So this is part of the policy. So I'm just going to read this bit out. Where concerns are raised regarding skin damage as a result of pressure, there is a need to raise it as a safeguarding concern within the organisation. In a minority of cases, it may warrant raising a safeguarding concern with the local authority. A history of the development of the skin damage should first be obtained by a clinician, usually a nurse, and if the person's care has recently been transferred, this may require contact being made with the former care providers for information to seek clarification about the cause and the timing of the skin damage. And this is the responsibility of the organisation raising the concerns. So it's really to consider that first, that scenario and maybe the history of the person who maybe you're be coming into your service now. So the pressure ulcer Hertfordshire safeguarding policy kind of looks at different categories. There's a lot of information there which we're going to send. We'll provide. We've got the link in it, and I think Verity said we can send the information out, and certainly the link will be there, and that will be sent. But so it's just to look at categories 1 or 2. It's not to say we wouldn't investigate a safeguarding concern, but we look at prevention first, and we don't ordinarily investigate these because we're looking at if a provider notices a pressure ulcer or a moisture lesion at early stage, prevention is key. So cases of single category, grade 1 or 2 pressure ulcers must be considered requiring early intervention to prevent further deterioration of damage. And of course, it depends on the category of care home, but if that's a nursing care home, then the provider may consider looking at the appropriate treatment. They might seek advice from a tissue viability nurse, and certainly a residential care home would likely liaise with the GP surgery and the community nurses in order to make sure that the appropriate treatment and care is in place and equipment. Category 3 or 4, severe damage in the case of pressure ulcers is indicated by multiple pressure ulcers of a category, a grade 2, or a single category, or grade 3 or 4, to include unstageable and suspected deep tissue injury. So we would investigate those concerns if as a provider there are concerns that perhaps something could have been done to prevent them from developing as a result of lack of action from others. So for example, if a resident or an adult at risk was supposed to be receiving maybe 2-hourly repositioning in bed and maybe assisted up in the morning onto an appropriate pressure relieving cushion, if there are concerns that, for example, things like that aren't actioned when they should be, that was likely that we would need to consider that under safeguarding. So I'm going to just move this again because I can't read that bottom bit. And so really consider this: if a professional has concerns regarding poor practice, they must ensure appropriate escalation through existing local reporting systems. And absolutely, if you feel that there is a concern that a pressure ulcer has occurred, certainly if it's a category 3 or 4 or above, including suspected deep tissue injuries, and they could have been prevented, or there's been lack of action that resulted in them, then please do consider that you need to report that under safeguarding. And again, we always as duty managers review those every time they come in. And if we want further information, if we feel it is or isn't safeguarding, it's really clear about the next actions. We make that, and that's always fed back to providers. Okay, next, Verity. Okay, so key takeaways. Just to consider that, again, I think my point is that not all pressure ulcers are due to neglect or lack of treatment. When considering safeguarding for pressure ulcers, please refer to the guidance, and obviously we've got the link there, and that will be available for you. You must consider medical conditions, the history and the monitoring of skin integrity, and previous professional clinical advice, and could it have been prevented? And I think they're the key things to consider when raising a safeguarding concern on pressure ulcers.
Perfect, thank you, Amanda.
Okay.
So I'm going to move on to notifications to the council. So we have got, and as I said, you will get these slides. The provider will be responsible for notifying the responsible area team within the council if any of the following occur. So we've got where the individual has consistently refused provision of the service, medication or medical attention. We've got serious accident, serious illness or serious injury, anything where the advice has been sourced. However, it is important to note that not all Regulation 18s do go to the council. It does depend on the situation. Death of the service user, outbreak of notifiable infectious disease, emergency situation such as fire or flood, legacy or bequest to the provider and or staff, unplanned absence of the service user, hospital admission, and investigation related to safeguarding or vulnerable adults, change of manager, and any notifications can go through See and Solve East Herts or West Herts via email, and again you will get this information. And also there is a document on how to access the social care in Hertfordshire. So 3 services, either non-urgent social care referrals. So that is requests for care and support for people living in the community, but do not require an urgent or outside of office hours response from social care. There's urgent social care, so those are for situations where care arrangements have broken down and the person requires an urgent response from social care. And then also safeguarding referrals as well, so to report a concern an adult is at risk of being abused or neglected. So this document has the service, how to refer, when to refer, and also any other contacts as well. And this will also be sent out at the end of the webinar. But it's important to note that CQC, based on those 10 points, CQC do not need to be notified on all of these. So I'm not going to go through each one because I'll be here for a while, be death by PowerPoint. But please have a read of this when you get the slides of also, you know, the differences between that HCC notification and also CQC regulation 18 and also other notifications. So it will be worth just making sure that you know, you understand those different expectations. And before I move on to Regulation 18, Jackie, is there anything that you would want to add based on those expectations? You're on mute.
Top of your screen, Jack, it's 3 little yellow dots.
There it is.
There we go.
Sorry,
That's
always me. No, I think you've covered that really in what you have there. I mean, I think you've covered that well, and what does need to go to CQC, and you know, that is the issue, isn't it? We've had in the past, in that it can be a bit of overload with all the notifications CQC receive, when actually maybe it's only us that need to know. So I think you've covered that well.
Perfect. Thank you, Jackie. And as I said, please have a read of this when we send the slides, just so you know, that emphasis is there, is that it doesn't go hand in hand, and that's exactly what Amanda said before. Regulation 18 doesn't always go hand in hand with a safeguarding as well, and that's the same for that HCC notification too. So on Regulation 18, these slides are a little bit wordy. So again, I'm not going to read every single word out, but I have highlighted some bits and pieces which hopefully just make it clear. And as I said, any questions, please put them in the chat and we'll get to them at the end of the session. And it is important to note that raising a Regulation 18 is necessary if been raised appropriately, as long as you're showing everything that you have done and evidencing correctly. So the first thing we've got is a serious injury. So either permanent damage or damage that lasts or is likely to last more than 28 days. So it does touch on here pressure sores as well, and injuries that lead to or often treated are likely to lead to that permanent damage, such as speech, thinking, remembering, judgments, etc. But that's all there. Abuse or allegations of abuse, instance reported to or investigated by the police. Events that stop a service running safely and properly. An outcome of an application to deprive a person of their liberty. And now when we think about falls, you're probably thinking serious injury, you know, that's really difficult sometimes to try and get some clarity on. I get many questions around, you know, types of falls, and we know there's some falls that happen from chairs. There's falls that might happen from equipment or even rolls out of bed. And it's really important to note that the type of fall is not relevant to making this notification. It is around if that person has sustained a serious injury. So a slip, a trip, a fall, roll from bed or near miss does not need to be reported if they have not sustained that serious injury. However, if there is that allegation of abuse linked to it and a safeguarding referral has been made, then it will be an allegation of abuse notification needs to be submitted. And when we're thinking about was that injury or is that injury serious, if there is advice sought from a prevention of admission service, GP, 111, etc., this doesn't automatically make it reportable. However, that does depend on the recommendation that where that clinical advice, what they've given. So if they have advice for any treatment or medical intervention, then at that point it would make it reportable. If it has been asked to monitor the individual, that isn't seen as treatment. So increased observations of the person to determine if there are any injuries is not treatment. I think the point is that if you seek any medical advice, then it could have that potential to be serious. But again, that depends on that advice received and if there is recommendation of any treatment. I think similar to what Amanda said with safeguarding, you know, we want to be checking that guidance, calling that National Customer Service Centre for advice, which is really important. And the National Service Centre is where many of the notifications are received. And sometimes there are occasions where they don't reach the inspection team. So there are occasions when notifications are submitted, but actually it wasn't the right appropriate action. But it's difficult for providers to get that feedback because you can imagine that could be quite a large job. So again, hopefully this helps you think and just make it a little bit more clear on what's needed. So anonymous information about the person, what's happened and the actions taken in response. And I think it's important to note, you know, again, what I said earlier is that those that know me, you know, I'm absolutely obsessed with evidence and making sure that we understand those falls and we do that root cause analysis. So understanding what happened where possible and the actions taken in response. including what measures you have had in place. So that involves that falls risk assessment, the equipment, the monitoring, everything that you've put in place because you were aware of that person's falls risk. If you're reporting an injury due to a fall, providing about, again, your falls interventions in general. Have you made sure that you've put your staff on training? Have you made sure that everybody's up to date with the current evidence, etc.? We want to see, I want to see, but also CQC want to see evidence of understanding somebody's falls risk. We have so much information on that. I will send you some previous webinars at the end as well on how we are looking at somebody's falls risk, root cause analysis, and then what we're going to do about it. And believe it or not, I see in care plans where somebody might not be a frequent faller, but they are still risk of falls, and they might have fallen 1 or 2 times that month. And in those interventions, it says there is no further action needed. Now, that's not enough for us to be doing to ensure that we're keeping that person as safe as possible and reducing the risk. As we said, we know they're going to happen, but we need to make sure we've got all of that correct evidence. A common finding, and I've put it in yellow because I think it's really important, is that to be able to share findings, sharing accidents around those falls with staff teams. Now, when I go and do training, I think there is such a fear sometimes that around people falling, which completely makes sense because, you know, the people I'm teaching have relationships with their clients or their residents or whoever it is, and nobody wants to see those falls happen or you know, severe injury. So making sure that we're including staff in the improvement journey of the service is a huge thing. It can really empower staff, and it can encourage a questioning approach. And that questioning approach is, you know, it's everybody's business. We want everybody to be asking questions. What could we do? Have we tried this? Or what about that? And that can really lead to empower staff and maybe try and reduce some of that fear that there sometimes can be. So looking at those lessons learned. As we know, falls are going to happen. We cannot stop them. We can reduce sometimes where possible, but we should be making sure that we have, you know, every person in that team is doing everything right. And then we can reinforce good practice and also best practice as well. So, as I said, those slides were a little bit wordy. Please go back, have a read of them. You're also welcome to email any questions after the webinar too that come to mind. But hopefully that's quite clear on what is needed and the expectations around sending notifications in, because I think everyone could probably agree that you have so much work to do and so much pressure. And if you don't need to do a notification, if that saves you time, then that's a really good thing. So hopefully that has been helpful. And we're going to move on to to go through some of the current kind of patterns and trends and a lot of the discussions that I've been having in the county at the moment when it comes to falls. So about one of the big questions, or one of the first questions I guess I always ask, is around structured medication review and has that happened? That is important for absolutely everybody, and not just, you know, certain members of staff being aware of medication side effects. We want everybody to be, even if they don't administer, and ensuring that we've got those reviews, looking holistically at an individual, because as we know, there can be many reasons why somebody falls, and we need to ensure that we are looking at all the options and trying to triangulate everything that relate to the falls plan. Looking at hydration and nutrition, this for me has been quite common recently, with looking at how, you know, weights and fluid levels have they been looked at in correlation to people who have been fallen, very much linking to infections and ill health. and especially around the winter time and how freezing cold it is, we've definitely seen an increase of infections, and making sure we're looking at hydration and nutrition as part of that, and linking that to falls. You're probably bored of me talking about enablement for independence, but it's absolutely where we have to go as a county to ensure that we are preventing deconditioning of people, and that we are ensuring, even if somebody is a falls risk, that they are moving, and that people are sitting less and moving more. Now, as I said, we know falls are going to happen. Now, my first response isn't about the number of falls. My response is, yes, but how many people are moving and independent? Because for me, that's everything. So looking at that, have we got the right skills there? Appropriate referrals, of course, to allied health professionals. Mobility and exercise, very much linking in to enablement and independence, but making sure we're also going that one step further. Rather than exercising in chairs, are we getting people up on their feet and balancing? And if people can't balance, can they practice balance as such? So things like standing up while helping with their own personal care, or standing behind a kitchenette and helping dry up the plates or wash up, or dancing, or gardening, and those kind of things are all part of how we can get people moving more. Of course, environmental risk assessments, and also as part of that, I can talk about eyesight, I can talk about sensor mats, call bells, I can talk about making sure there's no clutter on the floor and trip hazards and things like that. But I think we also have to be looking at the bigger picture than just those things. Positive behaviour support, and looking at distressed behaviours and mental health. Have we got the skills for people to support that, to have a root cause analysis of why somebody might be quite agitated? Because we know if people's mood change, that can link to falls. Fear of falling and reduced confidence in mobilising. Now, this is something that I feel like gets missed quite a lot with falls risk assessments. If not even from a fall, but if somebody has been in hospital or hasn't been very well lately, and they now are not quite confident on their feet, or maybe they become a little bit more withdrawn, they can start to have that fear of mobilising and falling, which means that changes every part of that person's positioning. Their posture, which means they might be more likely to look down at their feet and grip on for dear life onto their walking aids. And with that change in posture can mean that change in the shape of their spine, which means they become more rounded, which has got all the evidence to suggest that with a more rounded spine at any angle increases fracture risk and falls risk. So if we think about it with a preventative head, we think about, well, actually, okay, we know that this person is struggling to move from their bed, or maybe wanting to go outside, or whatever it is. Having some actions on how we're going to build that person's confidence slowly. And I'm sure you've all got fabulous stories of how you've done that, because I've heard many of them. In actually, when we think about that as prevention, then we are by default supporting somebody in their bone health to stand more confidently, to reduce that fracture risk and that severity, that if a fall may still happen, but maybe the outcome is better. So there's many interventions there, and I'm always happy to talk about these in more detail. Probably I could spend the rest of the webinar talking about them. But hopefully that's just thinking a little bit more outside the box. There is a drive at the moment around deconditioning within the county because of how people come back from hospital, what the last 3 years have meant for people's health and isolation and not moving as much, has led to a real, I mean, I've heard it being called another, pandemic of deconditioning. And though that deconditioning compromises of a physical, psychological, and functional decline. And that occurs because of people spending a long time in bed and associated with a loss of muscle strength. Generally, and you've probably all heard me talk about this many times and are probably bored of it, but we know that physical inactivity does contribute to 37,000 premature deaths, but also a mortality rate as well. Now, just being in bed, muscle strength can decrease up to 1.5% a day and up to 20% in the first week. When we think about it in terms of weight, kilograms, muscle mass, there is 1 to 1.5 kilograms lost from hips, bottom muscles, which are glutes, and quadriceps, which are in our thighs. And all these muscles absolutely vital for standing, for moving, for stability in our body. So every 10 days of bed rest is equivalent to 10 years of muscle aging, which is really, really scary. And I'm sure actually you've all seen the effects that this can have, as well as also changes in our minerals as well. We can lose body calcium 6 milligrams a day. So all of these things we have to start thinking about how are we getting people to improve, because in turn that will start to affect people's falls risk. So what do we want to start seeing then? This type of culture with all providers in Hertfordshire, that we're encouraging people to move. We have the skills to do that by taking up the right training, having the appropriate education, evidencing how we're keeping people out of hospital, how we're reducing falls where possible, everything that we've got in place. And that comes back to, those CQC notifications as well. That evidence to show everything that you have done is a huge must. When falls do happen, are we grading the severity of them? And I know many electronic systems do this in different ways, and we have got a form to support you to do that as well, which I'll send over. But looking at, if falls are going to happen, can we say that actually we've had X amount have caused no harm, and Y amount actually have caused moderate harm or have caused injury? And that's important to note as well. And we must think about bone health, and we must think about things like vitamin D, if appropriate, and how much people are moving. Specific actions, everybody is different. So these are not blanket interventions. They're not me telling you exactly what to evidence. These are, we have to be thinking about specific individuals. Practicing mobility and balance, as we've spoken about. Again, if you know about chair-based exercise, but that's not appropriate if somebody can mobilise standing and possibly exercise standing up with balance. It's a stepping stone, but how can it still improve people? Expectations of providers to be able to track patterns, trends, but ask for support. So if you know that there are falls happening in your organisation, and maybe you just want to chat about it, or maybe that you need to make sure that you've got everything that you need to ensure that you're asking for help. 9 times out of 10, it does get flagged by people, but come to either me or whatever support you've got in your organisation. Those conversations are always useful. Looking holistically at that person, and also making sure that we are using physical activity, and that's your everyday walking, dressing, gardening, dancing, cleaning, all those activities are into every day, but also your structured exercise, and making sure we're delivering that too, because that is treatment, and that's where all the evidence points to. Now, this information might be familiar to you. This is the management of when somebody has fallen in a care home pathway. The other pathways in the community are being reviewed currently, but there is supporting information that can support all providers too. So the pathway includes your red and your amber flag, so when to call 999 or when to ask advice from Prevention of Admission Service. Supporting paperwork to review which may affect medical treatment, If you do have a lifting cushion or any lifting equipment, when to use that if necessary. Required paperwork, so everything that we've spoken about at the beginning of the webinar, if required, and of course informing the right people. I'll send out all these documents, but and also a link to a previous webinar we've done on this. So we've got your red flags, and the red flags is done in a way called I Stumble. Now, I Stumble was developed by West Midlands Ambulance Service, and it's an easy way for people to remember those red flags. It's been lots of studies used against it, and also they are starting to possibly adapt for local pathways, so fingers crossed, and also fast test as well to be able to, you know, if there's possible stroke happening too. We move on to amber flags around other injury or illnesses, and to use prevention of admission services if further medical attention is needed. And I think that these are starting to be used really, really well throughout the whole of the county, which is great. We know the necessity of it to make sure we're reducing where we can the pressure on the ambulance service. So these are your amber flags, injury or illnesses. And also your post-falls assessment tool. Now, this is really useful for absolutely, it can be used in any care setting, but it's the document of the assessment of the person once those red and amber flags have been taken place. So possibly that person might need some basic health observations taken, documentation of consciousness, pain, injury, movement and mobility, looking at those factors to identify the cause of the fall, the outcome as well of the fall, full severity incident report form, and body map for assessment of injury. And this includes 24-hour post-falls observation log as well. So severity of form looks like this, and I know many of you will have your systems where actually it has your severity on there. So it might say major injury, minor injury, no injury, etc. This is helpful if you're not looking at that. So we've got no harm, low harm for the first two. Now, using this was signed off earlier in the year. But it's referenced in the NICE clinical guidance as well for falls assessment and prevention in older people. And the definitions of harm are published in 7 Steps to Patient Safety as well. So that's the first two. We've got then moderate harm, severe harm, and then lastly death as well. So all of these things ensuring that you're gathering all your evidence, all your information about that fall, and actually explaining, well, we know why their fall's been happening with the root cause analysis. We also understand the severity of our falls too. And actually, if we can see that people's outcomes are better, and maybe, you know, we haven't, that person hasn't had severe injuries, then that's also a really good thing. Because as we know, they are going to happen if people are mobile. So there has been quite a few, you know, questions, and Amanda touched on it earlier around raising a safeguarding, but we know around the ambulance long waits. So there's a dedicated falls desk in Bedford Ambulance Operations Centre with the concentration on welfare calls, intercepting long lies and advising food and drinks where appropriate. And this is their regional control room for Bedfordshire and Hertfordshire. And what's been happening in the county that locally CLCH have access to the call stack and be able to pick up some of these calls. CLCH only covers that of West Herts, but I know that there is the same similar in Herts Valley, and also East and North Herts as well. But there were some concerns around long waits and people being advised not to give food or drink for people on the floor. Now we know the effect that a long lie can have on the individual, you know, pressure sores, just pain, that it actually, by being on the floor, can have can increase mortality rates. So what has happened then, as this has been escalated, is that there is now an arrangement for tactical commanders to remove this section from the script, instructing no food and drink. However, that does depend on the surge level, so how long the delays are. If it is business as usual, then the original script will be used if there is an ambulance to be expected quickly. So just so you know, that information has come down after some concerns around those long waits and advising food and drink, because the last thing we want is people to be dehydrated and deteriorating even more on the floor. So how else can we help? You know, through falls, but also making sure we're keeping people as healthy as possible, and we're reducing that risk of deterioration, and we're reducing that risk of deconditioning, is through evidence in prevention and enablement. And this very much fits in to the effective key question, one of the CQC key questions of effective, I should say, which is about evidence in outcomes. So some key areas of that effective question I'll put up on the screen next. But we want to make sure where we can improve people's outcomes, looking at, right, how many people have we actually got out of bed? Because that's a really key thing. Somebody might say, well, we haven't had any falls, but that's actually because there might be a lot of people in bed, and that for me is quite a big concern, rather than people moving. Looking at how we are making sure we are improving independence, reducing those hospital admissions where possible, and focusing on both physical and mental well-being. So that effective key question, and this will be familiar if you were at our last network event where we went through them all, but making sure that we understand what's important to that person, that we're working effectively across teams as well, getting as much information as possible. We are ensuring that people manage their health and well-being, so they can maximise their independence, choice and control. Monitoring people's care and treatment so we can improve it, and that outcomes are positive, because that's everything I think we all strive for. And also we tell people about their rights around consent and respect when we deliver person-centred care and treatment. So again, many of you will know about this around our framework and where we want that evidence we've all been talking about, and that evidence has come out through safeguarding discussion around CQC regulation 18 and that notification, and what we're needing to say, well, yeah, this is everything that we're doing, but we want that to be as easy as possible for you. So we have a framework. It's got indicators in there. It can be a self-assessment framework, so you can do this yourself, and I will send a template over to you. But we want to ensure that we are promoting 10 topics that we feel underpin prevention and enablement. Around culture, and that very much links into, we don't want staff scared that people are going to fall. We want everybody to be involved, to have a question and approach, to ensure that we are looking to improve people. Governance, positive risk taking, very much linking into that culture too. Goal setting and outcomes, monitoring trends, knowledge and competence, so have we got the right knowledge areas, movement and exercise, engagement plans, thinking about, have we even thought about activity and one-to-ones and group activity, and if there's any correlation with that compared to unwitnessed falls in bedrooms or social isolation, or people living in their own homes and not have any links to community, to the community. Prevention of admission, and environment and equipment, and very much looking at those risk assessments. So there's lots of things here, and I'm always happy to talk through this, but as I said, you will get more information on this and the framework sent to you. but all of this to help evidence the steps that you're taking. And I'm going to finish on one of my favourite quotes, actually, which hopefully bring everything together really nicely. And then we've got a chunk of time left for any questions. Have sped through, we've just gone past 3 o'clock. But this was from a case around the least restrictive options. And this was from a judge who's called Judge Mumby. And he said that the fact is that all life involves risk, and the young, the elderly and the vulnerable are exposed to additional risks and to risks they're less well equipped than others to cope with. So just as wise parents resist the temptation to keep their children metaphorically wrapped up in cotton wool, so too we must avoid the temptation to always put the physical health and safety of the elderly and the vulnerable before everything else. Often it will be appropriate to do so, but not always. Physical health and safety can sometimes be bought at too high a price in happiness and emotional welfare. The emphasis must be on sensible risk appraisal, not striving to avoid all risk, whatever the price, but seek proper balance and being willing to tolerate manageable and acceptable risks as the price appropriately to be paid in order to achieve some other good. In particular, to achieve the vital good of the elderly or the vulnerable person's happiness, as it's what good is it making someone safer if it makes them miserable? So ensuring that, you know, with everything that we've spoken about today, always makes me feel like I want to cry that quote, that we can evidence everything that we're doing. We know falls are going to happen. We know you will raise safeguarding. We know you will raise Regulation 18s. We know you will notify Herts County Council. But if we can see that those things have been understood and root cause analysis have been done and all the right steps have been taken, then that's a good thing, and hopefully you get the support that you need to. So hopefully today has been useful to bring everything together and to be able to talk about everything on one platform. I'm going to see what questions we've got as we've got some time. Okay, so Amanda Bonds, this is probably for you, if that's all right. The first question I've got is, if a resident returns from hospital to a care home with worsening a pressure ulcer, we should contact the hospital or safeguarding. Please clarify.
I think there's no right or wrong answer, because every case would be different. So, but for example, I'm putting myself in the mindset of a provider. If you've received somebody back who's a resident with you that's been in hospital and their pressure ulcers worsened, I'd be looking at, is this clear in the discharge summary? So it's not necessarily a safeguarding. I used to work in an acute hospital for many years. And it's really, really important on the hospital behalf that they communicate. So sometimes pressure ulcers do. I'm going to just move. I'm so sorry. I've got a snoring dog, basically. I apologise. She's a French bulldog and she's very noisy. Have they communicated that? Is that on the discharge summary and with the relevant? So, for example, they should be referring to a district nurse if it's a care home they're going back to, a residential care home. Has any other treatment been given in hospital? Is there a reason why? I mean, it might be that they were just so unwell that their skin integrity was compromised further. So it's really about making sure that your communication from the hospital when you're receiving the resident back is paramount, really, and they've done all what they should do. It's really, if you feel that a pressure ulcer has occurred and you feel that it's worsened in hospital and you've got grounds to think it's as a result of neglect, and perhaps you've had no communication or lack of communication about the pressure ulcer, or you've received them back and you've got no clear communication on this ulcer at all, then I would be looking at, there might be grounds for raising a safeguarding concern at that point. I hope that answers.
I guess also, Amanda, is that if it seems a little bit tricky, is to give you a call and to discuss that with using a is it 24 hours you've got
Well, so
a
I
line?
clarified this. We don't have we don't have a
Not
24-hour
24 hours.
line because we have safeguarding out of hours that kick in when as the office day closes. I would say the portal is the best port of call because you can submit it with all the information and it's very quick. We review them every single day. All the day's report referrals are reviews that day. There's no wait. So if we've got further queries for that, we would then ask that information, which we do. For example, the 4 ones, we'll come back and say, well, are you, did you call a doctor at the same, are you saying that this might have happened because of lack of X, Y, and Z? So we always ask those information. So I think the portal is probably the best place, really, because if you're taking phone, it becomes a bit too much traffic that way. The safeguarding out of hours number is there for emergency. So if you really feel that risks are unmanaged and you really need to alert adult care services for that out of hours, absolutely. Or if you, the only reason you call in really is if you're wanting an update from an existing safeguarding, or you think that you need to urgently get hold of someone because suddenly risks are unmanaged. But otherwise, if you're if you're querying whether a safeguarding should be raised, obviously, hopefully there'll be the grounds to consider that first. But if your feeling is, submit it, because we would only give you the feedback anyway and give you further advice on what to do.
Thank you.
Hope that helps.
I've got another question around root cause analysis because we've spoken a lot about that. I don't have one, but let me come back to you, Lynn, as I've got these questions and see if I can dig one out from another team, because it probably comes up in some leadership training and things like that. So I'm going to go and find a colleague, and I'm pretty sure we've got a template. But so just hold out for that. I will come back to you. Someone else, we've got a resident with high risk of falls increasing every day and living with dementia. Falls pad often solves the corridor, so struggling to get a one-to-one, and it is an accident. Is this an accident and potential safeguarding? Who do we need to report this to, as we are trying to be proactive before an accident happens, not successful in getting help from social services? Please advise.
Could I answer that one?
I was going to say Jackie might be able to answer that. It's not necessarily a safeguarding unless an incident hasn't occurred or neglect, but over to Jackie because she'll give the answer.
What I would say with this is I do know how frustrating this can be for providers, because you may have taken somebody into the home, or be at home that you feel you could manage at the time and things have changed, or sometimes the assessment hasn't maybe given you as much insight into their needs as possible, and then you're trying to get support not only to keep that resident safe but also your other residents and your staff, because sometimes people are lashing out and their behaviors cause sort of a risk to everyone. And as I say, I do understand that in some cases, you've come back, they may have an open social worker already, or it may be that they don't, and you've put a referral in and heard nothing. What I would say in that case would be to ring the 0300 number and actually ask for the team manager for the team that that person sits under, because what will happen with cases, referrals will come through and they are triaged by one of the managers and put on a waiting list. Now, sometimes the severity can change and they need to be reprioritized. It could be that it's open to a worker who's gone off sick and you're leaving all these messages and nobody's actually picking up. So my advice would be to ring up and ask to speak to a manager, to make sure the severity of the situation is understood. In cases like this, I would kind of hope that the mental health team potentially have been contacted as well, because there might be something going on. Also GP, again, if they got some kind of infection, that can really sort of change things. I know I'm going back 20 odd years here, but I used to be a home carer when my kids were little. and you have your own rounds, and somebody goes sick and they ask you, oh, can you cover this lady? And I got the detail, went in, and crikey, this lady, I mean, she was just all over the place. Her behaviour was really sort of challenging and difficult. And I rang the agency really cross and said, oh, you could have told me this person had severe dementia and behavioural problems, because that's how she presented. To which they said, no, you're just going in to help wash her back feet that she can't read. She's perfectly normal. Because I didn't know her, I could have potentially walked away thinking, oh, she's a challenge. Thankfully, I was in my moaning mood, and so got a bit of feedback. But it turned out she had a really severe UTI, which came on quite suddenly, but the change in her behaviour was incredible. So, I think definitely always kind of get a GP advice, and say mental health. But if you are coming to us saying, we need help, we can't manage this person, definitely speak to a manager. It can be difficult because you may have, and there's cases that we deal with all the time. You've taken somebody into your home, you're telling us you can't manage and you can't keep them in the home, but we then have trouble trying to find another home that will take them. Depending on the risk levels, we may agree to one-to-one. Again, sometimes we'll be asked for 24/7 one-to-one, and we're thinking, well, people do have to sleep, so potentially you might agree some one-to-one in the daytime. But use of sort of like assistive technology like sensor mats, bed things, so that if they are sort of moving about in the night, then it's alerting somebody on the desk to perhaps pop down and see them, rather than somebody sitting there looking at them 24 hours a day. I mean, that's quite intrusive. So we do try and look at what that person needs. But again, it's about evidence. So, when you're putting a referral in, just kind of give as much detail as you can. Most of you, I would hope, kind of know who the team manager is for your area. Although I'm not an extended involvement team, and I'm kind of two hats at the minute, so I'm review team manager but also acting deputy head of service. But there's a lot of managers out there who know me and are just ringing and goes, Jack, we need to sort something out. Or like going back to the falls stuff, oh god, is this a falls, is it a safeguarding, what have you. So sometimes just sort of picking up the phone, if you've got that good relationship with your team manager, deputy team manager in the area, just sort of having a conversation, and if there's an open worker that you feel is just ignoring what's going on, again, you can flag it. Sometimes it will be that potentially somebody doesn't actually realize quite how serious things are. So again, just, you can't let it go. And sometimes we make mistakes and we will kind of prioritize things incorrectly, or we've got so many competing pressures. We're trying to, work out who we need with limited resources of staff. But, if you feel that there's something like that is an accident waiting to happen, and also if it does, you're then frightened that you're going to be accused of neglect or acts of omission, definitely raise it. Saying that, what I would like to say is, just because you've got somebody within the home that potentially their behaviours are in such that an accident could happen, as long, and Verity said this throughout, as Amanda, as long as you've kind of followed due process, so making people aware that there's an issue, that you may need more support. And this goes for falls as well. Verity says falls will happen. We know that, but as long as you've kind of considered all the things, reported it in, have got the evidence to say that phone, it is about recording. So if you can, it goes to Amanda and she may say, well, what did you do about it? And you can say, well, on this date, I phoned so-and-so, I spoke to so-and-so, I sent a referral in, or I sent an email. You've got very clear detail that you've done pretty much everything you could do. Safeguarding is not going to go against you. So, I think it's a case of just flagging it, asking for the manager if necessary, doing an email to the team manager. Again, you've got that copy there. And if you CC in somebody like See and Solve, again, it will likely, that will then be flagged in the team intake tray. So if that manager's off, somebody will see it. So, you know, all of this, we do get it wrong. Mental health get it wrong. Homes sometimes get it wrong, but it's then, what can we do just to make sure we get things right in future? What can we do to make things right for this person? And, you know, as a whole, not just answering that question, I think quite often it is about lessons learned as well.
Perfect. Thanks, Jackie. I think it's the same person. I think they've responded. They don't want to find alternative accommodation. The mental health referrals in, and the GP only deals with physical health. I think also with that is to make sure when it is behaviour, there is positive behaviour support training, making sure your staff are actually confident in how to support that person, and are we looking at all the root causes? Because again, as part of that evidence is, well, is it a certain time of day? Is it when a certain member of staff's on shift, or a certain time, or whatever it is, to say, well, actually, you know, we've tried to find that root cause. So that might be something as well you can take away. I believe we're doing a champion in it, and also a 1-day course. I think that's it, but definitely have a look if that's something maybe it would be useful for your other residents too.
Could I just say, Verity, I mean, if this is one that you feel you're in a serious situation at the moment, perhaps at the end, if you could let Verity know the name of the person and the home, I could then look into that for you and make sure it's flagged the appropriate people.
That would be great. Yeah, that's absolutely fine, Jackie. What I'll do is I'll put my email in the chat. So if there's anything that you need or want to urgently ask, then please feel free to email me. As I said, if we don't get to all questions now, we will follow up with you because we'll take these questions back with us. Okay, next question we have. Do you offer any training for homes around News 2 training? Yes, we do. So News 2, if you're not aware, is around spotting the signs of soft signs of deterioration, and that is part of the Restore 2, which is part of the escalation tool. It is used, it has been seen with other pilots that it can reduce hospital admissions, I think by 32% off the top of my head, which is huge. And some of you may only take them if the GP has asked you to, but actually being aware of those signs and being proactive to take them is a really great part of prevention. I will make sure that we get some information out on News 2. I'll put it in a follow-up email on some courses as well to come back to you with. But also on our member zone, we have all of the documents, everything you need when it comes to News and Restore. Okay. If a resident has all correct action has been taken and all staff have followed protocol, they have sustained a head injury. ECP or HARC, as it's known now, have attended. Does this need to be raised as a safeguarding and a Reg 18? Is this classed as a serious injury? So I think this is where a lot of confusion has been in the county with head injuries. And as the information that came from CQC has said, is it depends on that information that has been given. So you can call HARC or you can call whatever prevention of admission service, and depending on what they have said will depend whether it needs to be a regulation 18. So if they have said just monitor the individual, then that isn't seen as treatment. However, if there has been anything that has any other treatment or advice, then that would be a Reg 18. Does this need to be raised as a safeguarding? And I think, Amanda, quote me if I'm wrong, but unless there has been that abuse or neglect with that, then it wouldn't have to be. Amanda, is there anything else you want to come in to say with that? if the mute button is around, or unmute button. Oh, I think she's gone.
I don't know if it's helped, but I think, I mean, with that one, I would put that through as a regulation aid. See, I'm going to kind of answer this question, if I may, and the question below Debbie Scott about working in a care home and kind of like what CQC are saying and what we're saying, because this is kind of what causes issues, I suppose. And that is, you know, CQC can't be bombarded with hundreds and hundreds of emails that reg 18s that potentially they don't need to see because there has been no injury. However, you know, as a council, you know, what we like to say is, if somebody has a fall and it's just like a gentle slide from the chair, they've gone to go to the loo, they've tripped over, things we don't need to know about. If they've had a fall again and again and again, I would, you know, we would like to know about it, because what we'd be thinking is, hang on, what's going on here with this person? Does the home need a bit of support? Because if the person keeps falling, it might be that a second pair of eyes on it sometimes can make the world of difference. I mean, you know, sometimes you get somebody that's got full mental capacity, got Parkinson's, for example, and they're saying, no, I'm not using my frame. And you can tell them 1,000 times, but you can't tie them to it. You can't force them. So if they choose to get up and walk around, that we don't necessarily need to know. And I don't know if all providers do this, but some providers do send through falls analysis each month, and I get to see them as well. And that's really helpful, because then we can see kind of what's going on in a home. Quite often we might be worried because there's a lot of safeguarding activity, or at our professionals meeting that we have weekly, you've got a lot of professionals talking about stuff going on in homes, and we're thinking, hang on, there's been no reg 18s at all, either to us, CQC, etc. So, you know, it's difficult. The other thing is what people consider a serious injury, because what one person might think is a serious injury, another may not. So again, you know, it can be difficult. I mean, if Amanda may jump in and say, be quiet, Jackie, but if you know, I'd say sort of, if you feel that the injury is kind of serious, obviously CQC need to know. We as a council need to know about things that potentially you've needed to seek medical attention for. This is what I've kind of said in some of my chats with home managers. You know, if that person has come to sort of some kind of injury that you think, oh, I better get the ECP out, or call the ambulance, or seek medical advice because you're concerned about them, and then the ECP comes out and, I don't know, puts stitches in, glues it, or, you know, treatment, as Verity said earlier, I would like to see a Reg 18 on that, because it just gives us a bit of oversight on what is going on in the homes. And sometimes, you know, that might be that we make a referral to Verity's team, or we might talk to the CHIP team who go in, you know, so different. As I say, sometimes, you know, just a second pair of eyes, you know, another opinion on things may make the world of difference. You know, I found when talking to managers, sometimes they're kind of almost frightened to report stuff because they feel that every Reg 18 will then go to a safeguarding, whereas actually it's kind of more unlikely. You know, as long as you've done all you should do, you've taken all the appropriate actions, then it's just kind of advising us as what's going on.
Amanda, do you want Amanda Anstey, do you want to come in?
Thanks, Verity. Yeah, just a real quick point on that. So it is very clear on the CQC website and all the information that we give to the providers as to what is classified as a serious injury. So I do understand Jackie's point about, what might seem a serious injury to one person doesn't seem to another, but it is really clear on our website as to what needs to be reported under serious injuries. And I think when it comes down to Regulation 18s, just to remind providers that the Regulation 18 notification that you submit is what you send through to CQC. So if your reviewing officer does ask you about submitting a notification and they use the phrase Reg 18, just check with them as to what notification they're asking you to submit, because it may be your reviewing officer is, has just used, perhaps the wrong language to be clear to you, and making sure that, we all know who is reporting to who. And I'm just trying to work my way through a couple of questions in the chat about what comes under a Reg 18.
Perfect. Thanks, Amanda. And I think somebody also put in around HCC inspector said to raise any unwitnessed falls. Is this correct? This is a Reg 18 and a safeguarding. So again, what Amanda said is check with them with what they mean and who to report that to, because whether that is CQC or whether that is to HCC.
Sorry, Verity, just on that point. So in itself, an unwitnessed fall is not reportable under Reg 18. As we were saying, and as you said at the beginning, it's all about the injury. So if the person has sustained a serious injury, whether witnessed or unwitnessed, yes, it's reportable under Reg 18. But if it's an unwitnessed fall and there's no injury, it's not reportable to us at CQC.
Thank you, Amanda. That's great. Just having a look at any other questions. So we've had in the community who is expected to stay with the individual following a fall when they're waiting for an ambulance. We sometimes are quoted up to 12 hours and the family are refusing to come and wait with their loved ones. And then you guys end up staying because you can't leave them alone. I think that's really, really tough. But generally, for staff, domiciliary staff to stay for that amount of time, and sometimes if it's over that, you said once it was 48 hours, generally that advice would be for family to come and wait with them and to ensure that person is as comfortable as possible. I don't think there's actually any more I can really add to that. I'm just thinking if there's anything else. A few of you have asked to do some of our prevention and enablement work. There is, for both of your homes, there is things happening in the background of how we're going to do that and get to as many people as possible. Please, sit tight on that. However, happy for you to contact me, and if we could always start a chat going, and then hopefully we can do training in the best possible way, because I want to get us to as many people as possible. So because of pressure on hospital discharges, we've had the same individual discharged from hospital after 3 separate falls, but you wasn't fit for discharge. But because she took one step, they discharged her. After the 4th fall in 2 weeks, we refused to take her home and explained why we were refusing, and they just moved her to another provider. Would you raise this as a safeguarding?
Okay. First of all, it's really, really important, again, from working in an acute hospital for many, many years, if you as a provider, and I know the hospital pressure and the pressure they'll put on for care homes to accept back, and yes, absolutely, we've got to think, first of all, it's their home. So I know it's a care home, but that is their home. So we need to consider how long they've been there, and if the care home provider could support facilitated discharge aid, because hospital's not, it's not the best place for anyone to be in when they're medically optimized, when they're frail and elderly. So it's not for definite, but can that support back be facilitated? If so, if you're feeling that the needs are too high, as a provider, you need to be able to communicate that with them. If you feel you cannot meet that person's needs, you absolutely need to reassess if, as per whatever the process is within acute hospitals now. And if you feel you really cannot have them back, you need to be very clear about that. If there is a possibility that they can be discharged back to their home,
care home with additional support? Is that something that needs to happen? But the key is fundamental here is that the care home and the hospital, the discharge mustn't just happen without a conversation with the care home. That should never happen. They should always be made aware of that person's needs. If they've increased, does that person need, I don't know, a referral to the district nurse now from the hospital for a discharge? So a safeguard, we do get safeguarding on unsafe discharges, of course, absolutely. There is a theme, I guess, perhaps with the acute hospital or the acute trust is under pressure. But as a provider, be confident in the fact that if you can meet their needs, and if you can't, you need to communicate that. If somebody is discharged without communication back to a care home and you feel that's put that person at risk, that may be a safeguarding. But I think it's those communications prior to discharge to be really transparent about that person's needs, and whether you as a care provider can support those is very important as well. Has that answered? I don't know.
As they said, it was in the community, so I think.
Okay, sorry, in the community.
Yeah.
They should always be notifying the care agency, family, next of kin of a discharge plan. Even if a care is going to restart, that's they need. Well, the hospital needs to be clear that is a restart, and surely they should be liaising with the integrated discharge team and with the social work team. They should be getting involved. If they haven't, and you feel an unsafe discharge has happened without any form of notification and they've gone home, which sadly does happen from occasion, that would be a safeguarding concern. But my biggest thing is parallel to that, I always want to see past safeguarding and what needs to be done now to reduce that immediate risk. So not an ongoing risk, but what can be done at that time if someone is going to raise a concern to kind of mitigate that immediate risk. But yes, hospitals should be notifying, having communication first before discharging. I know that when they're in A&E, or that there's someone's an acute assessment part where they're not technically discharged, they're not technically admitted. So it's just to be really clear, because they may see that care shouldn't have been ceased, if you like, or stopped because they've not technically been admitted. But again, it's really open comms. Hospital trusts should be openly communicating with the next of kin or the service user if they have capacity, and the care provider. The care provider should always be aware prior to discharge and be able to say whether they can meet their needs, whether there's an increase that perhaps needs to be sort of looked at first, to if the person needs that kind of extra care. The communication is so key, I think, for a discharge. Very, very important.
Thank you, Amanda. I know we're just with 3:33, so we'll finish in a second and just make sure we'll get to any questions we haven't got to. Amanda, Anthony, you've got your hand up. Do you want to finish with anything?
No, sorry, Verity. Got
That's
carried
right.
away answering stuff in the chat. I'll put my hand down.
Great, thank you. I really appreciate that. I think somebody said, there is that confusion with that notification to HCC and the notification to CQC, which I completely appreciate. And obviously one of the big reasons why we wanted to put this on this afternoon. Hopefully that makes it a little bit clearer. That guidance on that serious injury for CQC is all on CQC's website, and read back through the slides because, as I said, they were really wordy, but the info was on there. Jackie, before we finish, do you want to add any last bit of advice for the HCC notifications?
No, I mean, I would say we don't want to be inundated. I would say have a conversation. You can always ring in and ask to speak to one of the managers or the open worker or me, just say, this has happened, what do you think? So you can always have a chat or drop somebody an email before you actually raise it if you're not sure, because they are quite lengthy, aren't they? And for us, it's just how you go about advising us. So as I say, I think what Amanda says about the language used is right, and that's something for HCC I think that we need to kind of pin down so that we are being notified. Maybe we call it by a different name, but just so that we've got that oversight as what's going on in the homes.
And HCC still need to be notified on those serious accidents and those injuries. Yeah, and especially when that advice has been sourced. But that difference with that CQC regulation 18 is if that treatment has been given, that treatment has been advised and that person is needing to be treated, not monitored, that isn't reported. So if there has been a head injury and you haven't necessarily called 999, because we know that's not always appropriate, and if they've said, right, we need to monitor this person, that isn't a notification to CQC. But you know, those but as Jackie said, notifying that to HCC may be necessary, right? Does that make
Yeah. And
yeah,
you know, if anything that you send over to, so Reg 18s, Reg 16s, you know, send to us as well, and then that way we know what's going on with people that we fund.
yeah, brilliant. So everyone, I hope that was helpful. Thank you for those of you that stuck around. We're just gone 6 minutes over. You will get the slides, you will get the recording. Please, any specific questions, my email address is there. I'm going to turn my emails on, aren't I? It's about 50 emails. I won't click on it just yet. But we are here to make sure we're giving you all the information that you need and supporting you where possible. So please use us, please ask the questions, ask for help if you need, and hopefully we can get that clarity, and hopefully you feel reassured as well, because as we know, these things are going to happen, but that evidence and all those things and learning, lessons learned and sharing that knowledge and looking at where we can improve is something we all want to see, and I think that does 100% happen. Heard great stories, but you know, hopefully we'll all get there, and yeah, hopefully this has all helped. So thank you very much.
So thank you for facilitating, Verity.
Oh,
Yeah,
pleasure.
thank you.
Yeah, so thank you to both Amandas for supporting all the information, and Jackie and your also colleague Tari as well for helping me out, and hopefully speak to you all soon. Thank you very much.
Thank you very much.
Thanks, Sarah.
Bye.
Bye all. Bye-bye.
Bye. Bye.